Good morning, friends. It gives me great pleasure to invite you all to the first masterclass from HSI on inguinal hernias. Now, I would like to hand over the mic to Dr. Ramesh Agarwalla from Kolkata. He is the president of HSI. He would briefly tell you about what this masterclass is all about and what the future holds for the members of Hernia Society of India. Over to you, Dr. Ramesh.
Thank, 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 thank you very much. Just with Sandeep, we've started. Hello? Sorry, Sandeep Dave was there. So thank you very much, Ashwin. The Hernia Society of India is a part of Asia Pacific Hernia Society. As we know, there are three major hernia societies in the world. One is the American Hernia Society, another is the European, and the Asia Pacific. We are the national chapter of Asia Pacific Hernia Society, and this was founded in 2004. Our first founder president was Dr. H.G. Doctor. And this Hernia Society, we have this, the whole aim is to propagate the art of hernia surgery. We have more than 12 or 1300 members all across India. And we are one of the largest part of Asia Pacific Hernia Society. We have a lot of academic activities, and we have very luminous past presidents like Dr. Chaube, Dr. M.G. Bhatt, Dr. Rajesh Kullar. They've all led to the Hernia Society to the form which is there. Now, we all know that life has changed with this lockdown and this COVID virus. And naturally, whatever programs we had thought about to be done over the year have to be remodified. We've had certain courses during the lockdown, and now we've started this series of masterclasses. This is the first masterclass on inguinal hernia, and then we are going to have two subsequent masterclasses on next Saturday and Saturday after that from 6 to 8 p.m. That is on ventral hernia 1 and ventral hernia 2. Followed by that, we'll be having some national and international webinars, and we will also have a virtual congress because we will not be able to do our annual congress otherwise. So we have a lot of activities planned over the next couple of months. I would request people who are not members of the Hernia Society to become members. It's very simple. Now it's online membership is open. You can just log into Hernia Society of India and become online member. If you become also the member of APHS together with Hernia Society, you will get the Hernia Journal online free. And there are lots of advantages. Once you become a member, you will know the academic content and the academic activities, and you will benefit quite a bit. I would like to thank Ashwin, who has taken a lot of pains to organize this masterclass. I would say he's the main architect. And I would also thank Kanavel, who has been very supportive. I would like to thank all the faculty who are on board and who have readily agreed to participate in this masterclass. So with these few words, the moderators for this session is going to be Ashwin and Kanavel. And I would request all the speakers, please stick to your time. And as it's a masterclass, we want the participants to ask questions, whatever the queries are. And the participants are supposed to put their questions in the chat, and the speaker will take the questions immediately after the talk. Now, I would pass it over to Ashwin. Over to you, Ashwin. Thank you very much.
Thank you very much, sir. Now we will just move on to the main program. The first topic is going to be on classification of inguinal hernia. It is going to be presented by Dr. Kanagavil, who's an executive member of HSI. He's a very good academician and he has a lot of interest in research and also the sterility and other parts of the accreditation. Over to you, sir, for this very important and relevant topic.
Good morning, everyone. Good morning, President Dr. Ramesh Agarwalla. Good morning, Dr. Ashwin, for being moderating this program in such a brilliant way, and all the efforts taken over the last week or so regarding assemble the program. I warmly wish Dr. M.G. Bhatt, our trustee of the HSI, Dr. Ramesh, Dr. Rajesh Kullar, past president, and all the faculty and the leaders of HSI here. I thank HSI for allowing me and giving me an opportunity to contribute in this forum. So let us get going. Kritika, am I okay?
Yes, sir. Your slides are very well seen.
Yes. So to start with, anything has to be done like with the divine permission or something like that. I invoke the divine permission to initiate the first talk, and I'm happy to be part of you. So it's full of stars. Everybody contribute, and as Dr. Ramesh Agarwal said, it is fellowship and academics. That is the Hernia Society of India's bottom line. And you can see the galaxy of Indian stars who have contributed, who continue to contribute. And we wish all of the youngsters to be part of the stars very soon. And once again, I reiterate the request of Dr. Ramesh Agarwal to become members of HSI. Thank you. Let us get into the business. So in one word, if you are going to ask me what is classification, classification is equal to communication. See, it serves as an anatomical blueprint. It assists in determining the most appropriate repair. It helps to correlate postoperative symptoms, duration of convalescence, and degree of disability. See, unless we have a classification, all this substratification and subset analysis becomes a challenge. And of course, with the amount of network-based analysis and all the data analytics which are shaping in a totally different way from the era of case reports to global databases, it allows correlation of the postoperative results and long-term follow-up with the original problem. So how it's going to be by flow? What has been the classification in the past in brief? I've already addressed why we are expected to classify and what are the fundamental basis of classification. And then what is the most current classification and the easiest classification for all of us to follow. So classify, purpose is already discussed. The scope of the classification is very clear, like in inguinal hernia. So you have to categorize what is an inguinal hernia definition. Then comes what are the components of inguinal hernia you are going to include in this, and what are the associated information what you are going to give in the classification. That remains the scope of the classification. And format, how we are going to standardize this. See, we have written format, you have online format, you have tabular format, but the current format what everybody is welcome to use is the grid format. The grid format is the one which is promoted by the EHS, and of course the Hernia Surge is a global network which has taken up in a big responsibility and which has simplified in a much easier way for everyone to follow. Then comes the variables. What are the variables? See, unless you set the variables running, see if it is right or left, if it is primary or recurrent, it becomes how big it is, and then you also need to categorize what type of groin hernia, direct, indirect, and femoral. These are the principal components. These are the variables one should look at to classify. See, this was the era when all our teachers were there. Fundamentally, they were told these are the types of hernia. I'm sure still these things are valid to talk, but then all of us in the era of database, data-driven practice, we should get into the appropriate classification. So the classical way to describe when we were students to our teachers where it's direct or indirect or femoral now has been worked on by many leaders in the past, starting from Nihas, Gilbert, Ratko, and everybody has contributed to improve upon and tried upon the classification. Ladies and gentlemen, I'm here to inform, but when there are many classifications, there are many ways to skin the cat. That's what it means. So let us look into how people have tried to attempt to bring things in order. So this was a very simple treatment-based classification by Griffith, and this is published by none other than Professor Stopa from France. And you can see all the top-notch co-authors there with them. Vance is there, Gilbert is there, Flamet is there, Chevreul is there. So it is very simple. He classified how we are going to approach. Are you going to approach from outside? Yes, that is inguinal approach. You can see that is the A. Then you are going to approach by B, that is your TEP approach. That's what he means, or the so-called stopa. Then comes your C, that is trans-abdominal. This simple was based on the approach. This was a very simpler classification which everybody could easily assimilate. Then came people believed, no, this is not adequate information. Then people believed they have to have more detailed classification. Then that's how Gilbert's came. He made point, he always firmly believed the floor of the hernia, the posterior wall, what we feel as transversalis fascia now, is the most important one. That's what he felt. And he classified 1 finger breadth or more than 1 finger breadth. So then again, how big is your finger matter? So these were challenged at some point of time. And how big is the sac? Is there a sac at all? Or is the bowel or the enteral content forms part of the sac or the Richter's one? But canal floor, see again, this was not very easily followable, or people found difficult to adapt this. Then came the vessel blaze classification, which partly is being part of the laparoscopic surgery as well. Initially, the vessels which were classifying were inferior epigastric artery, medial or lateral, and down femoral vessels, medial. The same thing on your left is the picture which shows the laparoscopic view, but then it is for the comfort and it is for the safety of laparoscopic approach. This follows good, either you follow a TAP approach, TEP approach, or an enhanced TEP approach. Then came, people really understood, this was a meta-analysis published by Dr. Stopa himself. He has tried to classify, now we do how we do stage grouping. He has tried to classify the groups. You can see how chaotic it is. I won't tell chaotic, but you will see how simplified now it is for all of us to follow. Then Stopa proposed a very simple thing, 1 to 4, but he brought in one other important point. The aggravating factor was also a contributing the factor or contributing variable for the classification. So it is, again, I would say it is much simpler than Gilbert's or the earlier ones. But again, this is where people started the importance of classifying, and then what is the most appropriate treatment for that classification. This was the publication which was early 91-92, and then this was published in the JAMA surgery, where people understood this complex, it was algorithm like. Then people firmly believe, no, I'm not sure, I'm going to follow this, this is too complex. But if you look at carefully, every day's information is still classified here, and every day's information is being applied here. But let us make life much easier. Then came the question of adaptability. That is where the European Hernia Society started as early as 2007. So they made life much easier. The variables were clarified. It made like a grid format, and then no finger breadths, or the finger breadths were defined with centimeters. So it becomes PR, and the lateral, medial, and femoral. And then the size becomes 0 is no hernia detectable, 1 becomes less than 1.5, 2 becomes less than 3, 3 becomes more than 3, and X is still you have not really categorically assessed. Then comes the important one. When you are talking about inguinal hernia, the pain component need to be assessed. That's where the groin plane classification, which was agreed with Doha Agreement. I will not be touching upon this as a much important thing. I'm sure Dr. Ramesh Agarwal is going to talk about this at the end. But this also gets classified in the groin. So there are 3 broad classifications which have been agreed by the global group. It says defined clinical entities are muscle-based first, then hip-based second, and then other causes of groin, especially in sports. So it is adductors, iliopsoas, inguinal, and pubic insertion points, one group, and hip-related thing or the hip joint related, and other causes of groin pain remains the tears and the neuropathies of sportsmen. So this becomes very easily classifiable. So once people are comfortable with EHS, I would appreciate they also know this classification. When these both are combined, it becomes a very clear message You don't need to write a ton of a length of a case sheet. You just mention EHS class this, groin pain classification this. People understand the severity of what you are trying to do. Then people will jump on me. Do we have a consensus for this? Is there a global acceptability? You can see how important is the classification. This is a very recent publication on the 2018 hernia surge classification. The entire hernia surge group have resat again, and they have tried to integrate all the groups, the American Hernia Society, European Hernia Society, APHS, and overall. If you see, when compared to the other factors, classification is catching up. I would say close to 80% of the people are right now adapting the classifying parameters of the EHS. But let me tell you, it is so easy. All of us, once we adapt to a single system, now, however little be our data contribution, if it is appropriately classified, it is duly recognized in the global database. So I'm sure all of us will be able to implement this very, very simple classification format. Then people may still challenge, sir, what we are telling is may be right. I'm not sure what is the recommendation at this point of time. The 2018 consensus was the EHS classification, what is based on it, were weak. But if you are going to ask me why it was categorized weak, I need to address to you yet another important issue. All these classifications are essentially need to be confirmed with the post-operative finding. That is the only challenge the EHS classification at this point have. But I'm sure the change from the clinical classification of the hernia and operative classification of hernia is not, vast difference is not noted. I'm sure they are easily cross-exchangeable and adaptable. I'll reiterate with this closing slide. P is primary hernia, R is recurrent hernia, 0, 1, 2, 3, and X. 0 is when there is no hernia detectable or occult hernias, less than 1.5 centimeters, less than 3 centimeters, more than 3 centimeters, and yet to be investigated comes under X. And then very simple as lateral, medial, and femoral are the very simple thing. So it's going to mention P2L. It becomes very simple. It is as easy as that. And maybe I can appreciate if you can add this grid format as a either a rubber stamp or in a printed format of your prescription, hernia prescriptions, or your discharge summary. You have to make only one cross over there on the LMF and 0, 1, 2, 3, and you will have the P and R classified up, and you are done. Thank you for your attention, and thank you, HSI, for giving me the opportunity.
Thank you very much, sir, for that elaborative talk. So the classification is very important because we all have to talk one common language. If Dr. Agarwal tells me that this is the hernia which he has seen, then you also would understand what exactly the hernia dimensions and characteristics are. So with this, we will move on to the next talk. I would request the audiences to please type in your questions in the comment box, and we'll be happy to take them at the end of every talk or at the end of towards the end of the program as well. So now it gives me great pleasure to welcome Dr. Manish Baijal, who's the Honorary Secretary of HSI, to deliver the talk on inguinal anatomy, a laparoscopic view. Over to you, Dr. Manish.
Good morning, everyone, and thank you, Ashwin, for organizing this and getting all of us together on a Sunday morning. So now going ahead from what we have started to do this morning is talking about endohernia repairs. So are my slides visible?
Yes, sir, the slides are visible.
Okay. So talking about endoscopic groin anatomy, there was a very interesting survey that we had done a few years back under the banner of Hernia Society of India that looked at how many surgeons actually do laparoscopic groin hernia repairs. So out of 100 laparoscopic surgeons, you would find about 29% only who perform laparoscopic TEP or TAPP repairs. And there were about 32% out of these 100 who actually started doing these repairs and gave it up. So what were the reasons we tried to look at? And the topmost reason what was given to us was the cost of surgery was higher. So when they were working in smaller places with limited money available for the surgery, so cost was number one. Number two was difficult anatomy. So a lot of surgeons said it was difficult for them to master this anatomy, perceive this anatomy, something that they have not learned before. So a lot of surgeons who started and gave up because of inability to learn this anatomy. Number three was a little more difficult surgery as compared to other basic laparoscopic procedures. So there was inhibition to get into another learning curve, learning the new anatomy and working in a limited space. And number four was the possibility of major vascular injuries, because whenever we look at anatomy, there are various pretty scary looking names which have been given to structures. So this was one of the another reason for people to give up surgeries. Now, what I have tried to do in this presentation is I've tried to keep it absolutely applied. So I would not show you any sketches. I will not show you any diagrams. I'm only going to show you the anatomy as you encounter when you do endoscopic repair. Now, when we do this, when we try and learn this anatomy, why is this anatomy different as compared to what we see in open or anterior repairs? Number one, you are looking at the groin from the umbilicus. So you're not looking above downwards, you're looking parallel to the groin. Number two, you're looking inside out. So when we do laparoscopic repairs, these are called posterior repairs. So why do we call it posterior repair? Because we are posterior to the fascia transversalis. So fascia transversalis forms the floor when you do a open repair, and it forms the roof when you do a laparoscopic repair. So you're looking inside out. And number three, you try and unlearn the anatomy, what you had learned while doing anterior repairs, and you try and relearn because you are now posterior to fascia transversalis. So it's a new anatomy. So essentially, I divide this learning of anatomy into 6 important steps. Number one, you must know the space in which you operate. Number two, you must know the important landmarks which are to be identified and dissected where. Number three, as you encounter the anatomy, what do you encounter medially when you start doing your dissection? How do you address this anatomy laterally? Which are the rare hernias and how do you see them? And last but not the least, a word of caution. So the space. Now this is a pre-peritoneal space. Now this is below the arcuate line, so we do not have a posterior rectus sheath here. So as I was saying earlier, the roof is formed by the rectus muscle and fascia transversalis. That makes it a posterior repair. And posteriorly, it is only the peritoneum because of deficient posterior rectus sheath below the arcuate line. So that is the pre-peritoneal space in which we operate. Now, how do we get to this space? There are 2 ways to get to this space. You access it directly, that is called a total extraperitoneal repair. And number 2, through the peritoneal route, which is called the transabdominal preperitoneal repair. So when I'm trying to show you the anatomy here, this is essentially going to be an extraperitoneal approach. Though the space is the same, the anatomy is the same, you will see the same anatomy when you see the presentation of transabdominal preperitoneal. So this is going to be essentially preperitoneal, the total extraperitoneal repair anatomy. Now, the space in which we operate, the preperitoneal space, was first described by Nias. Now, this space medially is called the space of Retzius. This is below the pubic bone. That is the space of Retzius. And when you go laterally, it is called the space of Bocros. Now, what do we repair in this space? We repair the entire myopectineal orifice of Frouchard, which was talked about way back in 1956 with not much of importance, but is extremely important now for you to understand. This is what we repair when we do a laparoscopic repair. So this is basically a potential orifice through which you can have herniations, which is bounded by 4 musculoskeletal structures. So medially and above anteriorly is the rectus abdominis here. Laterally and inferiorly is the iliopsoas. Superiorly, laterally is the conjoint tendon, and inferiorly is the pecten pubis. So these are the boundaries of a myopectineal orifice. And what are the 3 potential hernial sites? So if you look at, this is the inferior epigastric vessels. Medial to it is the site for your direct hernia. Lateral to it is the site for your indirect hernia. And below the iliopubic tract, between the Cooper's ligament and iliopubic tract, is your site for femoral hernia. So myopectineal orifice basically talked about 3 potential hernial orifices. So what are the important landmarks in this space that you have to encounter? See them, dissect them well. Until unless you've seen all these landmarks, you've not dissected the space well. So you have medially the pubic bone, laterally, inferiorly is the Cooper's ligament, and laterally, superiorly is the iliopubic tract. Now, what is iliopubic tract? Iliopubic tract is similar to inguinal ligament anteriorly, but we are in the posterior space. So this is condensation of fascia transversalis that extends medially from pubic bone to the anterior superior iliac spine. So this iliopubic tract actually divides the space into superior and inferior compartments. The superior compartment has direct and indirect hernia, and the inferior compartment has femoral hernia. The 2 direct and indirect superior hernias are bifurcated by inferior epigastric vessels. And then, of course, you see the spermatic cord, iliac vessels, and psoas vessel. So now we will look at the anatomy as we encounter it as we start dissecting the space. So the medial dissection, this is what you do first when you do a total extraperitoneal repair. So what is the first landmark that you encounter in the midline? As you see here is the pubic bone. Below that is the retropubic space, or the space of Retzius. When you start moving laterally towards the side of hernia, you encounter the direct sac if present. Reduction of direct sac exposes the Cooper's ligament and the iliopubic tract, as well as the inferior epigastric vessels. Now, this is just a picture. So the picture on the left side shows pubic bone. You cannot see the the Cooper's ligament clearly because you have a structure going superiorly into the anterior abdominal wall, which is nothing but the direct hernial sac. When you pull the direct hernial sac down, you see the stretched fascia transversalis, which is also called a pseudosac. This is the only time when you actually encounter a fascia transversalis while doing these repairs. And the moment you reduce this, you see the Cooper's ligament clearly, and you see the hernial defect as well as the inferior epigastric vessels. So this is exactly what you see on this video. Now, video is on the left side. You see the inferior epigastric vessels on top. This is the direct hernial sac, and that is the fascia transversalis. And moment you reduce this sac, you see the Cooper's ligament becomes clear. You start seeing the spermatic cord, and on top is the inferior epigastric vessels. So this is the picture that you see. Inferior epigastric vessels, medial to inferior epigastric vessels is the site for your direct hernia. This is the Cooper's ligament, and the lower boundary of the direct hernia is the iliopubic tract, which extends from pubic bone laterally to the anterior superior iliac spine. Between the Cooper's ligament and the iliopubic tract is the site for your femoral hernia, and that is the deep ring lateral to the inferior epigastric vessels through which the cord structures go, and you have the site for indirect hernia. So now we are looking at the right side, the lateral dissection. Once you have done the medial dissection, encounter the anatomy laterally. You see the inferior epigastric vessels on top that you've just seen. You see the hernial sac along with the cord structures if there is an indirect hernia. So the hernial sac lies lateral to the spermatic cord. And moment you divide this hernial sac or reduce it completely, you encounter the triangle of doom. I'll come to that a little later. So this is the video of how you encounter a indirect hernial sac. So these are the cord structures, and anterolateral to the cord structures is the indirect hernial sac. You can see the glistening hernial sac, and this is how you separate the hernial sac from the cord structures. This is not to give you the tips of dissection, only to show you the anatomy. Okay, so you have the hernial sac in the left hand and the cord structures below. So if it's a complete hernial sac, you ligate and divide. And moment you have divided the hernial sac, the cord structures become visible. The medial boundary of the cord structures is the vas. The lateral is the testicular vessels. Floor is the base is formed by the peritoneum, which we have just divided, which was going through the deep ring. So the apex is the deep ring. And what are the contents? The contents are the iliac vessels. So the terminology triangle of doom. So you have to be careful when you dissect in this space because of the presence of major vascular structures there. Now we go laterally. The anatomy absolutely lateral to the cord structures, and which is called the triangle of pain or the quadrangle of pain, which you have to be aware of. Now, what is this? You have cutaneous nerves deep to the fascia over the psoas muscle. Two important nerves. Now you have the femoral branch of genitofemoral nerve and the lateral cutaneous nerve of thigh. So what is the importance here? You don't have to actually try and identify those nerves in every case, because when you try and identify, there are chances of injury. So two important points here, that the nerves lie deep to the fascia of the psoas muscle. Okay, so if you do not injure this fascia, you prevent injury to the nerves there. So do not use any diathermy below the level of iliopubic tract, as you see here. No diathermy in this area, and preserve the fascia over the psoas muscle to prevent any injuries. So this is how you access the space laterally. That is the psoas. Do not bare the psoas completely. Stay superior to this fascia over the psoas, and you can actually see the nerves there. So no diathermy. Preserve the fascia over the psoas to prevent injuries to this cutaneous nerves. So that is the anatomy laterally. And this is how a completely dissected space looks like. So another word here on anatomy. You see, this is the pubic bone. Below the pubic bone, in the space of Bogros, you see that white structure. This is the Cooper's ligament. And that white structure is the obturator nerve. And the obturator foramen lies here. So laparoscopic repair not only repairs the three earlier hernias I talked about, it also potentially repairs a potential obturator hernia. This is how a space looks like once it's dissected completely. So the two other hernias that we have talked about, how do you encounter them? So you've seen Cooper's ligament. This is the Cooper's ligament. If you have a hernial defect above it, superior to it, it's a femoral hernia. If there is a defect below it, it's a obturator hernia. So that's a femoral hernial ring, which is the medialmost compartment there, and lateral to it you have the external iliac vein, and the lateral most is the external iliac artery. This is the Cooper's ligament. You see the obturator nerve below it, and this is a obturator hernia. And once you reduce this hernia, you see the obturator foramen there. So these are the two potential hernias, and this gets me to the last slide, which is a word of caution. This is the triangle of doom that I've already talked about. Number two, another major structures, what we talk about is also called the Bendowitz circle in the space of Bogros. And there are various other terminologies, but I would like to stick to call it Bendowitz circle, which is nothing but a plexus of veins from the superior epigastric, inferior, not superior, the inferior epigastric, the external iliac, the aberrant obturator. So there is a plexus here. So you have to be careful when you dissect the cord structures here, because this is where this important veins lie. So the bleeding from that area can be extremely torrential. So you have to be careful when you dissect here. And of course, maintain a good asepsis and ensure an empty bladder, because bladder is here in the retropubic space. If you have this bladder full and you are new to this surgery, there are chances you can land up with an injury to the bladder. So this is about anatomy of the endoscopic anatomy of the inguinal region. So I hope I've been able to make things clear. If you have any questions, I am there to answer those questions. Thank you very much, and back to you, Ashwin. Thank you very much.
So thank you very much for that wonderful applied anatomy lecture rather than having it only as a tutorial demonstration. Some of them would like to know what is the ideal repair for an inguinal hernia. Is it lap or open? Could you take that question?
Now that's a very difficult question to begin with. If you look at most studies worldwide, there's very little to choose from as far as the recurrence rates are concerned. But if you look at laparoscopic repairs in the last decade from high volume centers, this is the only surgical procedure in which we have been able to document recurrent rates of less than 1%, which was earlier documented by the Shouldice Clinic. So as far as recurrence rates are concerned, there's very little to choose from. But without any doubt today, the incidence of chronic groin pain as well as earlier return to physical activity is much superior with laparoscopic repairs than with open repairs. So if you look at totality, low recurrence rates, least incidence of chronic groin pain, early return to work, of course, laparoscopic repair. Of course, if the expertise is present, laparoscopic repair is a preferred approach.
Thank you very much, sir. So now we move on to the next lecture, which is the transabdominal preperitoneal repair. So I'll be giving that lecture. I'm an easy member of HSI. So it already has a recorded version of the audio in the presentation. So I'll just go on with it. Start by showing how to put the ports. So here you can see in this patient, supra-umbilically, that is where we will put the camera port. This is the head end. On the right side, the side of the hernia, lateral to the inferior epigastric course, which corresponds approximately to the lateral edge of the rectus, is where we'll put the working port, and it will be in line with the umbilicus. Whereas the left working port, because it's a unilateral hernia, will be 2 centimeters below the umbilicus and medial to the inferior epigastric vessel. If it was a bilateral hernia, we will make the left-hand working port also in the same line of the umbilicus, lateral to the inferior epigastric vessel. So now that we have shown you how the port configuration looks like, so here you can see this is a complete right reducible indirect inguinal hernia. The first important step in TAPP is to position the bowel. So here we have given a head low, and you can even have a slight light rattled up. And here you can see we have put a Foley's catheter, that is the Foley's bulb. Just a brief anatomy before we start with the procedure. So that is the vas deferens which is present medially. That is the vas, and this is the testicular vessels laterally. Inside the triangle, you will have the external iliac. So that is the triangle of doom. And this is the nerves which you see laterally and the psoas muscle. So the testicular vessels and the iliopubic tract will form the triangle of pain. The base will be formed by the reflected portion of the peritoneum. So the importance of the triangle of pain is to make sure that there is no fixation below the iliopubic tract. So that was the inferior epigastric vessel which was seen, and the hernial defect was lateral to it. So it's an indirect hernia. We gave a compression on the outside, and we saw where the anterior superior iliac spine is, and we are starting the peritoneal incision from close to the anterior superior iliac spine. Here we have made a small tattoo close to the inferior epigastric vessel and also 3 to 4 centimeters above the hernial defect, so that we know that the peritoneal incision should go towards the tattoo and it should not be deviating towards the hernial defect, which can happen during the initial learning curve. So it's always a good practice to have multiple small tattoos so that we have a guide on the direction in which we have to carry our incision on the peritoneum. So here you can see the transversalis fascia very nicely, and we are pushing it with the hook instrument towards the roof or the anterior abdominal wall. Once again, you can see the transversalis fascia clearly. So we're using a cautery and then pushing the transversalis fascia. So whenever we are developing the peritoneal flap, you do not have to be confused whether you have to leave a lot of fat or not. The peritoneum has to be thin. So now you can see the inferior epigastric vessel coming close by. So there we won't use any cautery and we will just push the tissues away. So the peritoneum has to be flush and you have to keep it thin. And when we go closer towards the medial umbilical ligament, we just make a vertical incision on the peritoneum. We should not go transversely beyond the medial umbilical ligament. The medial umbilical ligament is the medial landmark and we have to stop that. If we go beyond that, there is a possibility that we can injure the bladder. So now the vertical peritoneal incision which we gave on the peritoneal flap is really helpful for us to open up the retropubic space of Ridgius. So here you can see the space is opening up and the carbon dioxide is slowly opening the planes, and we can see some amount of the white cobwebs kind of a tissue, which is the area through which we have to dissect. So now you put your assisting hand inside and you can see the carbon dioxide is again opening up the planes very nicely. And then you just use a little bit of cautery whenever there is a fibrous strand. So now you can see the Coopers is starting to come into our picture. You can see a nice yellow pad of fat which is present. That fat has to be left with the anterior abdominal wall and you should go below that. You can even go above it, but that is not the right plane. You will have a lot of these small vessels and it will lead to a lot of oozing. So now you can appreciate clearly we are working between the fat and the perivesical fat which is covering the bladder. So now you can see the Coopers is becoming more prominent. We'll just take the instrument inside. You can see the reflection is becoming bright. So that is because of the reflection of the light. So again, we are further dissecting in the right avascular plane. You can see short burst of cautery is used. And then we complement it with a blunt dissection as well. We have to carry our dissection in the same manner till we have an overlap of at least 2 centimeters beyond the pubic symphysis, because that is where the mesh coverage has to be present. So now you can see the left Coopers also is coming into the view. The pubic symphysis is nicely seen in the midline. There is a small collection of vessels running over there. And the inferior dissection below the pubic bone has to be just for a couple of centimeters. You do not have to go too low. So once that dissection is over on the medial side, now we come towards the lateral end to open up the space of Bogros. So here you can see just pulling the peritoneum and using a cautery is opening up the planes. That white structure which you're seeing is the iliopubic tract that will run from the anterior superior iliac spine to the pubic symphysis, and you have to make sure that you do not do any fixation below the iliopubic tract. All the fixation has to be done above it so that you do not have a fixation on the nerves, which can lead to chronic pain for these patients. So now you can see gradually we're using a short burst of cautery and carrying a dissection towards the sac. Whenever we are doing this dissection, it has to be between the peritoneum and a small fascia which will be covering the nerves on the abdominal wall. We'll be showing you the fascia shortly. So now you can see here there are some transversalis fibers which we are just incising in a sharp manner using the monopolar cautery. You can see the fibers very clearly now. We'll be demonstrating it a little better shortly as well. So we just keep teasing these transversalis sling fibers until we see the bare peritoneum. That is the objective for us. So now you can see a little bit of the transversalis sling fibers have been dissected already. So now we are just pushing and teasing the tissues away. So here we are holding the fascia which is covering the nerves. So that is important, so that the mesh does not sit directly on the nerves, causing chronic irritation. So here you can see a little more of these transversalis fibers and the facial attachments are released so that the peritoneum can be dissected in a nice manner and only the peritoneum will be present. So once again, you can see the transversalis fibers very nicely. These fibers will come from the lateral side, peritoneal sac anteriorly, and then will run medially. So we have to release the transversalis sling fibers on all these sides so that the peritoneal sac will be bare and you won't have any of these fibers pulling the peritoneum back into the hernial defect. So here you can see we are releasing the medial fibers now. Again, we will just release the sac and hold it a little more higher and pull the sac lower down so that we have a good traction. So you can see as soon as we leave the sac, it is being pulled inside. This is because still all the fibers haven't been released. So here we have some facial fibers and attachments which are present, which we are releasing. If we had a direct hernia, it will be in this area. But here there is no direct hernia. It's just the facial attachments which are present, which when released, you can start to appreciate the Cooper's ligament a little more clearly. So here you can see the carbon dioxide has already dissected the space nicely and is showing us the right dissection plane. So that is the corona mortis vessel, which is a abnormal anastomotic vessel between the external iliac and the inferior epigastric or the obturators. And you can see these vessels are quite prominent. They look very small, but if you injure them, there will be torrential bleed. So that is why they call as the circle of death, and we have to be very wary and careful around these vessels. If at all there is an injury, it's better to use a good bipolar to control them. With the pressure of the carbon dioxide, they'll be collapsed and they will look like a small docile vessel, but actually they can bleed profusely. So here you can see some more of the corona mortis vessels are being identified just to the right of my instrument. And here also you can see the vessels running. These are all the anastomotic vessels which run in that area. So here we're just dissecting a little more to see the obturator area and make sure that there are no small fat which is protruding as a hernia in this area, or there is no obvious hernia as well. So here you can see gradually we are carrying with our dissection, and shortly you will see the obturator vessel very nicely. So that is the obturator nerve which is coming into the picture to the right of my hook instrument. So once we see that, we know there is no obvious herniation. So again, now we come back to the dissection of the sac. So here you can see the transversalis sling fibers still present. So we're just dividing them in a sharp manner using a monopolar hook. And now we have just converted to a Midline forceps. We're using a short burst of cautery, and then we will gradually tease these tissues away. Whenever we do a dissection of the sac in an indirect hernia, we should always start from the lateral side and go medially. This will make your dissection much more easier. So again, you can see a few of the remnant transversalis sling fibers which are present, which are easily taken down. You can see how nicely we are able to tease these vessels away from our area of dissection. So here you can see we are just teasing the tissues away. And now you can see a bluish hue is starting to appear. That means you do not have any more tissue, and it is just the dissected space which is already done near the bladder. So here we just keep continuing in the same plane. Then we will encircle the sac completely. So here we're just going to make a small opening, and you can see now we have gone beyond the sac and we have encircled the sac completely. So my assisting hand is holding the sac, and on the right side you have the vas and the testicular vessels present. So here we're just using a short burst of cautery whenever there is a small vessel running. We try to keep the usage of cautery as minimum as possible in this level, close to the vas, because we do not want any thermal injury happening to the vas. So here you can see we are holding the entire sac in our left hand. You can see these small facial attachments whenever present. We're using a little bit of the cautery and gradually carrying our dissection a little more further. So all these small fibrous strands have to be released so that the sac is completely free and we have a good length of the sac available to us. Whenever there is a complete hernia, I do not try to reduce the sac completely, because it can lead to small oozers and even compromise the vascularity to the testis. And whenever these bleeders are present after retraction, they form a hematoma, and there is a higher potential for the hematoma to be infected rather than a seroma. So all these patients are counseled, they will have a small seroma. It will automatically get better. So here you can see this is the distal sac which we are dividing. Once you go beyond the deep ring, you can divide the sac at any level. Here we have gone even beyond the superficial ring. You can see that the peritoneum was absent in that area. So after division of the sac, we have to continue with our parietalization and do a comprehensive parietalization further, so that the inferior limit of the dissection also is fulfilled. So the inferior limit of our dissection is the area where the vas turns medially and goes under the medial ligament, which is formed by the obliterated umbilical artery. So my left hand is holding the obliterated umbilical artery, and here we're just dissecting the area where the vas is going and turning medially and running inferior to it. So you can see the area now very clearly. The same line of inferior dissection and paratalization is going to be done on the area where it is close to the testicular vessels as well. So here you can see some fibrous attachments which are holding the vessels close to the peritoneum. So we are just pushing and teasing these tissues away so that we have a good paratalization done, and we can have a mesh placed very nicely without the raising of the inferior limit of the mesh. This is one of the commonest causes for recurrence in a hernia, either in a TAP or a TP. So this is the completed picture of the peritoneal flap. You can see it is intact without any buttonholes. We just pull the upper flap of the peritoneum slightly. Now we are placing a 15 into 12 centimeter mesh, and we're using a Pdids suture to be fixed to the Cooper's ligament. We are not using any tackers to reduce the cost for the patient. So we always like to do a 2-point fixation. So this is a fixation on the anterior abdominal wall above the iliopubic tract, medially at the level of the rectus abdominis muscle. Then we do the closure of the peritoneum with a Pds suture, which is a monofilament. The advantage of using a Pds is you can take 2-3 bites together and then pull the tissues together. A small tip is to hold the needle now, keep the needle in the same driving position, hold it with the needle holder, and then pull the thread together so that you can automatically go and take the bite quickly without too much of a manipulation of the needle required. So this is how a direct hernia would look like. You can see the inferior epigastric vessel and the medial umbilical ligament. The hernia is present between them. So this is how the transversalis pseudosac would look like, and here we are pushing the pseudosac, and the hernia is held by my assisting hand, and you pull it away and you just tease it gradually. These pseudosac would get reduced completely. If there is a small vessel, we can use a short burst of cautery, similar to how I'm doing it now. And you can see the Cooper's is still not visible, and only now it's coming into the visibility. Once again, you can see the inferior epigastric vessel and the rectus muscle. So here, this is a suprapubic hernia. You can see the hernia is present between the medial umbilical ligament and the median umbilical ligament. This is pretty much bang on the midline. And here you can see this is the right medial umbilical ligament, and the hernia is present medial to it. So again, the hernia which you're seeing now is a suprapubic hernia, whereas on the left side, you can see it's a direct hernia, which is lateral to the medial umbilical ligament, but between the inferior epigastric vessel and the medial umbilical ligament. Thank you very much for your patient listening. So there was a question earlier on asking about the cost of hernia surgery. So whenever you need to do a hernia surgery, if you are very good at your suturing, even for the fixation, you can do a simple suturing, and that would reduce the cost for the patients a great deal. With this, there were no more questions yet. So we'll just move on to the next talk, which will be on TEP repair. And this talk is going to be given by Dr. Rajesh Kullar, who is a trustee and past president of HSI. I now request Dr. Rajesh to take over the session and give his presentation. Over to you, sir. Sir, you are muted, sir. Please unmute yourself, sir. So you're still muted.
Yeah. Good morning, everyone. And I thank Dr. Ramesh Agarwalla, Dr. Ashwin for starting this initiative of Masterclass from Hernia Society of India. In the present time, this is the best forum where we can continue educate and teach our young budding surgeons the art of herniology. Thank you very much. Can you hear me?
We can hear you well.
Yeah, so I'll share my screen. Yeah, so I'll be speaking on TEP. Now this, you have already listened to the anatomy as well as the TAPP approach, which is another approach for laparoscopic inguinal hernia repair. TEP is slightly different from TAPP, where you enter into the preperitoneal space directly without entering the peritoneum. This was started by McKinnon and pioneered by Professor Dulac. The anatomy which we see, as you have seen already, we look at it from the umbilicus and not directly, and we look inside out as compared to what we do in open surgery where we look from outside in. And this is the most important area in the anatomy for hernia, because you can see the whole of myopectineal orifice of Foucault, which is the area of weakness where the hernias can develop, direct, indirect, suprapubic, all hernias. So the idea of laparoscopic repair, whether transperitoneal, TAPP or TEP, is to cover this myopectineal orifice of Foucault to give extra strength in this area to prevent any hernia formation. So the two techniques, I'll be talking about the totally extraperitoneal. Now, there is a potential space between the rectus muscle and fascia transversalis anteriorly and the peritoneum posteriorly. And this potential space can be approached by open technique and directly and enter into the space to place the mesh without entering inside the peritoneal cavity. Now, the important thing is that because the anatomy is new and the technique is new, so one has to learn to master this. Training is very important, and that is what we are sitting here and doing. Proctoring during early experience is very important, because once you have learned, you must have somebody to guide you through the patient to do a procedure safely. And once you have started doing it, it is very important to standardize your procedure. You standardize your steps, follow the same steps every time, so that chances of mistakes are minimized. And I always say that you must know your limitations. If you attempt a procedure and you find that it is too difficult for you, you are not able to do it well, there are always other options which you can continue doing and not insist and harm the patient in any way. Now, for TEP, there are certain points. You must choose a patient in the beginning. The pre-op preparation is important, and then few steps which will go one by one after this. Now, when you choose your patient in the beginning, it is important to select simple cases. Now, what is going to be a simple case? An elderly male who is thin-built and who is fit for anesthesia, because the surgery is to be done under general anesthesia. So such a patient with no previous surgery, especially in the lower abdomen, because that will cause increased adhesions between the anterior abdominal wall and the peritoneum. So that should be the patient selected. And from hernia side, if it's a right, direct, incomplete, and reducible hernia, that is an easy hernia to do by TEP technique. Another point, that if the distance between umbilicus and pubic symphysis is more than 15 centimeter, it becomes slightly easy to do TEP by the technique which I'm going to show, in which all three ports are made in the midline. In the operation theater, it is important to empty the bladder because we are working in that area. Normally, we ask the patient to pass urine just before coming onto the operation table. If on ultrasound there is significant residual urine in elderly patient, we put in a catheter. We ask our anesthetist to give good muscle relaxation, because only then the preperitoneal space opens up. Because we are in a space which we create ourselves, the space is limited. It is slightly different from the TAPP approach, where you are inside the abdomen and you have all the intraperitoneal space to work with. The arms of the patient are kept on the sides, and the surgeon is on one side of the patient. Rather, the surgeon is on the side opposite to the side of hernia which he is going to operate, and his camera person, it's better to be on the opposite side. We have seen that in the beginning you should start with 0-degree telescope, but ultimately 30-degree scope gives you a better view of the lateral spaces in TEP as well as in TAPP when one has learned how to do it. The pre-peritoneal access is the most important. We do it by open technique because it's reproducible, and it can be done by an average laparoscopic surgeon. I prefer to give an incision starting from midline to one side because we want to go to the anterior rectus sheath of one side, and then use, you separate, go up to the anterior rectus sheath, give a horizontal incision on the anterior rectus sheath, and take stay suture from two cut edges of the anterior rectus sheath. These stay sutures will make this port airtight later on. Retract the rectus muscle laterally, you see the posterior rectus sheath, and use a balloon which you can make yourself. Go parallel to the posterior rectus sheath towards the pubic symphysis and inflate the balloon. And once you remove the balloon with your trocar fixed, this is the space you see which has been created with peritoneum below and the rectus abdominis in front. Now, the advantage of using this balloon is that it is, doesn't cost anything. You can prepare it before starting the surgery. Little bit space you can make with use of your telescope to increase the space. And then you put 3 ports, 2 more ports in the midline only. The upper port is about 5 centimeters below the telescopic port, and the lower port is about 2 centimeters above the pubic symphysis. The advantage of putting all the 3 ports in the midline that you start your dissection with 2 hands from the beginning. You can do both sides hernia with the same ports, and it also reduces the incidence of inferior epigastric injury because inferior epigastric is laterally placed and not in the midline. And this is how you put your 2 ports. After putting first port, you can increase the space with the help of your instrument in the midline to put your second port so that you work with both the ports. The important thing is to understand this anatomy. You must see the pubic bone in the midline, glistening white with the Cooper's ligament on it. Laterally, as you go, you have the iliopubic tract. You have the inferior epigastric artery in front. Inferior epigastric artery in front. The testicular vessel and vas deferens going down. You have the peritoneum here. This is the medial space of Ritzius, and bladder is here. Laterally would be the psoas muscle. And this is the direct hernia. That was on the right side. This is on the left side. You have the femoral ring here. You have the indirect hernia here. You have the direct hernia here, and the obturator hernia is in this place. Now, this is how you start surgery. The first thing is to feel for the pubic bone because you can't see anything in the preperitoneal space. So with your instrument, you feel for the pubic bone and open up the avascular plane between the 2 layers of transversalis fascia. You feel for the pubic bone and open up the space. Once you see the pubic bone, you further go laterally. And if you don't see the Cooper's ligament, you see the direct hernial sac. You pull the direct hernial sac downwards and push the transversalis fascia up. And the gas in the preperitoneal space helps you to push the sac away from the peritoneum. And this is how you reduce the direct sac. You can see the direct hernia there, and the peritoneum has come down. In case of indirect sac, you pull the sac down and out and separate the sac from the cord structures from the lateral aspect. Just with the tip of your instrument, you push the cord structures laterally, advancing onto the sac till you reach the end of the sac. And once you reach the end of the sac, you open up this space, ligate the sac like we do it in open surgery, and cut the distal sac. You can leave the distal sac in the sacs, but make sure there is no bleeding. And once you have divided the indirect sac, the next step is always look for the lipoma in this region, because any lipoma in this region can be the cause of recurrence, as well as, if not recurrence, it will keep giving patient the feeling of having the hernia still even after the surgery. So always look for a lipoma whenever you reduce the direct or indirect hernia. That is very important. During separation of lipoma, be careful and you must identify the fat which is normally along with the cord structures. There is always a plane between lipoma and the cord structure which must be reduced completely. Next is good parietalization. Catch hold of the peritoneum and push the cord structures away. Use short burst of cautery. You can see the peritoneum clearly. You have to medially bring down the peritoneum till the vas turns medially, and laterally you have to bring down the peritoneum till the level of psoas, so that the mesh lies flat over the psoas without getting raised up when it is placed in this space. That's the lipoma. You can excise the lipoma of the sac and you can see the psoas in the lateral space. Medially, you can further bring it down till the vas turns medially. Now that is the good parietalization, so that there is no lifting of mesh later on. Laterally, you open up the space between the two layers of transversalis fascia by using two instruments. You can see the nerves over the psoas, the lateral cutaneous nerve of the thigh, and the genital branch of genitofemoral. Bring the peritoneum away from the anterior abdominal wall so that your mesh lies properly on the anterior abdominal wall, anteriorly as well as the psoas behind. Now the mesh used is 15 by 13 centimeter. We fold it partially so that placement of mesh is proper. Like this, we fold the mesh so that about 5 centimeter of mesh is open, and we keep it in place by putting 2 stage sutures. And this is how the mesh goes in. We fix it with a tack, 2-point fixation, just above the pubic symphysis, not in the bone, but above the pubic symphysis, and 1 tack in the Cooper's ligament. After opening up the mesh laterally, especially in an indirect hernia, I prefer to put 1 tack on the interior abdominal wall to keep the mesh in place. The important thing is asepsis, which is the most important thing in any laparoscopic hernia. To reduce seroma, you can, especially in a direct hernia, you can pull the sac down and fix it onto the Cooper's ligament or on the anterior abdominal wall to prevent seroma formation. If there is any peritoneal tear like this, while separating it from the cord structure or anywhere, a small tear need not be tackled, need not be sutured, but a large tear like this, you must always suture these holes so that the proline mesh doesn't come in direct contact with the bowel at all. And you must counsel these patients always for development of seroma in the post-operative phase, which many of them develop. For take-home message, the creation of preperitoneal space, balloon dissection and telescopic dissection have similar outcome. You always dissect from medial to lateral in case of TP repair. The landmarks visualized are very important, and you must always familiarize yourself with these landmarks before you start doing this surgery. Extensive preperitoneal dissection is critical to prevent upfolding of the mesh. The mesh should be minimum of 15 by 10, but preferably 15 by 13. And an early return to normal activity can safely be recommended. I'll show a full video in this. You can see okay, I think I'll have to go back and
so you can try playing the video separately, sir.
yeah, I'll do that. I'll do that. I'll exit from here. Can you see my video?
So you'll have to share your screen once again.
Can you see my video?
Not yet, sir. You have to share your screen.
Okay. Can you see my screen?
So we are seeing you right now. We are not yet. Yes, sir. Your screen is starting to come into place. We can see the video now, sir.
Okay. Okay, so that is the indirect inguinal hernia. So once you are in the space, use both the instruments to open up the lateral space like this. That's the advantage of having both the instruments in midline. You can under vision separate the peritoneum. You can see the inferior epigastric artery on the anterior abdominal wall. Keep dissecting till you see the transversalis muscle laterally. And then pull down the avascular tissue, the fibers of transversalis fascia, medially as well as laterally. Bring down the small fibers and pull the sac down and out. That's the deep ring, that's the sac. And once you see the indirect sac, the trick is to pull down and out from the deep ring, because then you get the narrow neck of the sac. At the base, sac is wide, but if you pull it out, you go to the narrow part of the sac. Separate the cord structure by teasing it and using short burst of cautery. Same way as we do it in open surgery, keep advancing on the sac till you go to the edge of the sac. You can see the edge of the sac here, and then go around the sac. So inferior epigastric, the deep indirect defect, the cord structures, the sac. And I always prefer to ligate the sac proximally and leave the distal sac open, because that is what we used to do in open surgery also. And it is not difficult at all. It is imperative that all of us laparoscopic surgeons know suturing and knotting, and it's simple to put knot on this sac. And then divide the sac. If you reduce the sac completely, do not forget to open the sac. So make a small nick in the sac to open it up so that there is no collection of fluid in the sac. And then do peritalization by pulling the sac away from the cord structures, vas deferens, spermatic vessels. Do not hold the cord at all. At any stage, it is preferably not to hold the cord, and do not hold the peritoneum for more than 30 seconds at one place, because peritoneum is single cell layer. It will get traumatized if you keep holding it. And then open up the space, lateral space, the triangle of pain. You can see the nerves. By opening space like this, you always have a layer of fascia over the nerves, so your mesh doesn't come in direct contact with the nerves at any stage. And this is how we make 15 by 13 size mesh. We roll it and put 2 sutures on the flat side of the mesh, and that faces us when we put it inside. And make sure you put it on the psoas, 2-point fixation medially, and then open up the mesh and then lift it up and deflate. The peritoneum comes up and keeps the mesh in proper place. Thank you very much.
So there are a lot of questions for you. So
yeah, sure.
The first question is, what is the difference between a conventional TEP and an E-TEP?
Yeah, you see, conventional TEP is when you access the preperitoneal space from infraumbilical space, you get space only below the umbilicus. Now, in large hernia, large direct hernia or indirect hernia, or interior abdominal wall hernias, where you want to have excess or extra preperitoneal space, you need to access the space from higher up. So your first port goes much higher on the anterior abdominal wall. It could be 3-5 centimeter above the umbilicus over the rectus muscle, and from there you access the preperitoneal space. That way you can do even preperitoneal repair for umbilical hernia, so that becomes extended TEP. So if you extend the preperitoneal space above the umbilicus, that becomes E-TEP.
So the second question is, what is the recurrence rate after laparoscopic hernia?
You see, if you see literature at present, the recurrence rate after laparoscopic hernia is almost same or maybe slightly less as compared to open hernia, which is around 1%. But definitely there are papers, lot number of papers, where the recurrence rate after laparoscopic repair has been duck recurrence, means no recurrence at all, even in series of more than 200, 300 cases over a period of 5 years. Our experience has been over last maybe 5 years, we must have done more than 500 cases with one recurrence, which I remember. Apart from that, the recurrence rate is very low after laparoscopic repair. Important thing is that you have to learn this technique. Only then you should start doing it. Learning is very important, and learning is not only by watching videos on YouTube or in a conference. Learning, you can do it only after watching it. You have to go to a center where a good amount of work is being done. You stand there, you watch the surgeon doing surgery, then you start yourself with a proctor standing behind you, and then you take it forward. That is very important. Any more question?
So what do you do for a recurrence after lap hernia? What is the management protocol?
Yeah, the management protocol is after laparoscopic hernia recurrence, you should always do interior repair. Yes. When I say that, that is what is recommended all over the world. All hernia societies recommend that. But an expert hernia surgeon will be able to do recurrence of hernia after laparoscopic repair, again laparoscopically, but that has to be a TAPP approach. It cannot be done by TEP approach, always TAPP approach. But one has to be very, very careful the incidence of complication in surgery for recurrent hernia, laparoscopic repair are much higher than the primary hernia repair. So my recommendation would be that in such cases, do anterior repair because those planes have not been transgressed in laparoscopic repair. And it will be like doing a primary anterior repair.
So there are actually a lot of questions, but I'll probably just take 2 or 3 more, and at the end, if we have time, we'll take the rest. What are the advantages of putting the ports in the midline?
Yeah, as I said, to put a lateral port in TP repair, you have to create the lateral space because the port has to come in the preperitoneal space. So you have only one instrument in midline with which one hand you keep opening the space, and chances of opening up the peritoneum are much more if you have only one working port as compared to if you have two working ports. When you have two working port in the midline with one instrument, you press the anterior abdominal wall up. With other instrument, you push the peritoneum down. And with gas being in the preperitoneal space, the space opens up automatically. That is number one. Number two, you can do both side hernia by just changing the side of surgeon and the camera person from one side to other side. Number three, you never injure the epigastric vessels because they don't come in the midline, they are lateral. Number four, the chances of port hernia are almost nil if you go in the midline because midline you have good strong linea alba as compared to the lateral ports. When I say that, the chance of port hernia is much, much less after TP repair as compared to TABP repair because in TP repair, you don't go inside the peritoneum at all. So these are the few advantages of keeping both the instruments, all three instruments in the midline.
So I'll put this as the last question. Do we necessarily always have to fold the mesh, and does the mesh have to be fixed in a TP repair?
Yeah. You see, this question has been always there. You see, the advantage of folding the mesh, there is no documented thing. Or if you are a good surgeon, you can handle a large mesh in a small space, no harm done. But what we have seen is that if you take some steps which makes your life easy, the chances of making mistakes are much less. The most important step in TP repair is placement of mesh properly for prevention of hernia recurrence. That's it. Everything before that, what has been done is preparation of that particular step. So I want to fix my mesh properly where I want to put. So I reduce the size of my mesh to 1/3, put it properly, and because I make space little larger than the size of the mesh, only then you can put your mesh properly. In that case, I feel more confident by fixing the mesh at 2 points just above the pubic symphysis and in the Cooper ligament, which prevents rotation or lifting up of the mesh. Lateral tack is optional. So it helps me in proper placement of mesh and gives me satisfaction of putting the mesh in a proper place.
Thank you very much, sir, for those answers.
Thank you.
We'll just move on to the next topic, which is going to be a panel discussion on complications of inguinal hernia. The session is going to be moderated by Dr. Ramesh Agarwal, who's the president of Hernia Society of India. And we have some stellar panelists collected over here with you. Most of them have more than 25 years of laparoscopic inguinal hernia repair experience. So first, I would like to introduce Dr. Anil Sharma, who's a past president of Asia Pacific Hernia Society and Hernia Society of India. Dr. M.G. Bhatt, a past president of Hernia Society of India. Dr. Ramesh M., who's a vice president of Hernia Society of India. Dr. Sandeep Dave, who's the immediate past president of Hernia Society of India. With this, I now hand over the mic to Dr. Ramesh Agarwal for an exciting session.
So thank you very much, Ashwin. Can you see my screen?
I'm able to see you, sir, not the screen yet.
Right. Yeah. So can you see my presentation now?
Yes, sir. Your screen is visible now, sir.
Yeah, okay. So thank you very much, Ashwin. As Ashwin has said, I'm really honored to have such esteemed panelists with me. And it's giving me a bit of goosebumps also. So there are two talks about these two parts to this panel discussion. One is the complication and one is the decision making in hernia surgery. And Ashwin, am I audible, Ashwin?
Sir, you're audible, sir.
Yeah, Ashwin is already introduced. Dr. M.G. Bhatt, Dr. Anil Sharma, Dr. Sandeep Dave, and Dr. M. Ramesh. So what we are going to look at, two different scenarios. One is the perioperative, and another is the postoperative. So we have this sometimes, we have a irreducible hernia or obstructed hernia, and as soon as the patient goes under GA, there is a spontaneous reduction. We encounter bleeding, and has been very well said in the anatomy session by Dr. Manish Bajal, and also been further elaborated by Ashwin and Dr. Kullar, the important areas where you can run into trouble. And then there is a bladder injury. And in postoperative, we have the main things which we look at is seroma, which I wouldn't call it a complication, but it is something which happens. And there is infection, which can be a disaster to the patient and the surgeon. And one of the most important yardstick which we look at is the recurrence. So we will go one by one. I will start with Dr. Anil Sharma. And I would, before we start the panel discussion, quite a few of these videos have been shared by the colleagues, and they're not always mine. So Anil, we are having this 54-year-old male, obstructed right inguinal hernia for 8 hours, early skin changes, spontaneous reduction under GA. What would you prefer to do now?
Yeah, thanks, Ramesh, for your question. This sort of a scenario, obviously, one needs to be careful because there has been a spontaneous reduction of the hernia under general anesthesia. So I would like to make make sure about has been reduced back to the peritoneal cavity. So that would entail, say, performing a diagnostic laparoscopy initially to view the contents of the hernia that have reduced back to the abdominal cavity. So, like we are seeing on the screen right now, a diagnostic laparoscopy to view the reduced contents. And like in this case, you can see it was bowel that was in fact reduced back to the peritoneal cavity. You have to ensure viability of that segment of the bowel before you can in fact tackle the hernia. So in short, perform a diagnostic laparoscopy, look at the reduced hernial contents, and then make your surgical decisions from there on. So we'll start off with the TAPP. That's what I want to say because of the diagnostic laparoscopy.
So type of repair is the next question. So I would further just add here that even if you're not doing a laparoscopic repair, and if there is a spontaneous reduction, you're a person who's only doing open hernia repair, you need to look at the bowel. So diagnostic laparoscopy is very, very essential, which is very important. Now we've been the anatomy lectures and the subsequent lectures have really told us about these triangles, triangle of doom, triangle of pain, and triangle of disaster, and what is the importance. So Dr. Bhatt, the next question, this is a TAPP procedure for a recurrent groin hernia. So this patient had a recurrent groin hernia and the patient had open arrived stopa before. This is the history of the patient. And then what you see is, this is the procedure. So, Dr. MG, what do you think? Which vessel has been injured here?
It looks like, you know, a major vessel has been injured here.
Yes, it's a
And,
iliac. Iliac, yes.
you know, this is
Yes.
the drawback of people trying to do laparoscopic hernias, recurrent ones, that too laparoscopically. And when they are not experienced, I think the person is not experienced and he was just dissecting and got into this trouble.
So, what would you do in this scenario?
It's a difficult situation at the moment, and I think in today's practice, he uses initially stop the bleeding with some graspers. He can use the graspers to stop the bleeding, analyze the situation, and call for help from a vascular surgeon to repair.
So, call for help, which is very, very important because.
But he can use the grasper to stop the bleeding, so the bleeding is stopped.
Yes. So, you have to call for that. That is very important. But, and you convert. And Dr. MG, why did it happen? I mean, it was basically a wrong choice of the procedure.
No, I think I would look into this way. One is unable to understand the anatomy, which means the person is inexperienced. He did not understand the anatomy in something. This is a previously operated case, so it's actually a recurrent hernia. So basically, it is inability to understand the anatomy, and that's the root cause of the problem.
Yes. So because this space has been already violated, because if we see this is open right stopa was done. So, you know, we always try to go to a virgin plane, which Dr. Rajesh also said during his talk, that when there is a laparoscopic recurrence, we do an anterior repair. So, Dr. M. Ramesh,
Yeah.
so you see this video.
Yeah.
So what vessel do you think, Dr. Ramesh, this is?
Yeah, this is the inferior epigastric artery.
Yes.
The deep one.
Yes. So what do you do? How do you control the bleeding?
When compared to the other vessels that normally get injured in inguinal laparoscopic inguinal hernia repair, like the iliofemoral or the corona mortis, I think we are in a better shape here. The inferior epigastric can be held, can be obliterated using clips. It can be obliterated using energy sources like a bipolar energy or a vessel sealing or a ultrasonic scalpel, and then we can go ahead with the surgery.
Yeah. So you hold the artery, you do a bipolar. Sometimes you might need to do a suture, or as you rightly said, we can also apply clips, and they also help. So this has been talked about in the previous lectures. So this is another area where you can have a bleeding. So you have to know that there is a pubic artery, pubic branch from the inferior epigastric, and there is another pubic branch which is coming from the obturator. And when these, when there is a bleeding from this area, so what would you suggest? How does one control, Dr. Ramesh? Suppose there is a bit of bleeding from the corona mortis, how does one control this bleeding?
This is going to be a very difficult one. The first and foremost that we would like to do is put pressure there.
Yes. Yes, Ramesh, we can't hear you anymore. Yes. Yes. Dr. M. Ramesh, we are not audible.
I think there's some problem with the connection. Could you ask the question to a different panelist, sir?
Yes. So, Sandeep, can you take this question? If there is bleeding from corona mortis.
Well, it's a very difficult area to deal with. And yes, the only thing which can save you is compression and patience.
Yes.
Compress the area wait patiently for 5 minutes to 10 minutes, and then relook. Reduce the pneumoperitoneum. Or you can actually put a compression externally also on the pubic bone as well as internally with a gauze piece through a suction. You can compress that area. The compression is the only way by which most of the time you can actually control this bleeding. If you are able to pinpoint, the source, then you can cauterize it with a bipolar. Otherwise, it is very, very difficult. It is known as circle of death. So better to avoid any bleeding from this. Prevention is better. If the bleeding occurs, compression is the only way to deal with it.
Yes, Sandeep.
In my practice, I've always compressed it.
Yeah.
Sorry, I went out of.
Yeah, so Ramesh, Sandeep has answered your question. He's done it so well. So now, Sandeep, this is yours. This is the TAPP procedure, right?
Yeah.
This is being done.
I think urinary bladder has got open.
Yes. So this is a urinary bladder. So what would you do? One is to the hernia. One is to the urinary bladder. What would you do to the urinary bladder?
Urinary bladder, laparoscopic closure with a Pds catheter to remain in situ for at least 2 weeks' time. That is the way we are going to deal with the bladder injury.
Yes.
Regarding hernia,
Yes.
definitely I'll not like to do at least a transabdominal preperitoneal repair now. I'll switch over to either an open anterior repair or I'll postpone the hernia surgery if the patient insists. If the patient has asked for a laparoscopic repair for the next sitting, otherwise I may do a open anterior repair rather than going for a laparoscopic repair in the same sitting.
So this is the message which we want to give, because though there are people who argue that urine is sterile, but you can never be sure that urine is going to be sterile. So you should never put a mesh there. And Sandeep, why do you think this happened?
This is happening because, again, what MG also said, not knowing the anatomy well. You have crossed the medial umbilical ligament, which has not to be cut.
Yes.
You have to remain lateral to the medial umbilical ligament when you are opening the peritoneum. Your incision limit has to be lateral. You never have to cut the medial umbilical.
Yeah, so that is very important. That is the importance of anatomy. Anil, just this is again a TAPP.
Yes.
So the dissection has been complete. You can see now the medial dissection is being done. It's just gauge piece dissection. And you see we have an injury of the bladder. You can see the Foley's there. Now, why do you think this happened?
See, Ramesh, in these sorts of bladder injuries, what happens most commonly is that, there are, in fact, factors that may point to a possible bladder injury in the patient. Now, some of these factors are, for example, a recurrent hernia, or for that matter, any surgery that has been performed down in the pelvis. So
Yes.
any previous surgery in that region would lead to a fair amount of the adhesions, fibrosis, and when you in fact go down there subsequently try and dissect, you are in fact liable to have bladder injuries. So when you have these sort of scenarios, or for example, long-standing hernias, that have been there for in fact decades on end, very large hernias. So with these, sort of scenarios, you must try and in fact preempt this from happening. And one of the ways you can do that is to put in a Foley catheter indwelling preoperatively, or in fact, just before surgery. So that keeps the bladder empty, and chances of a bladder injury are less in that sort of a scenario. But like I said, this remains, a factor to be reckoned with when you are in fact dealing, with surgery in a space that has been operated on before. You have large hernias, when you have sliding hernias, when you have complex hernias, this sort of a scenario is to be expected.
Yes, so I totally agree. What we are looking at two different scenarios. One was, the anatomy was not adhered to. And here, again, if you can see the mark on the videos, the patient had some form of pelvic surgery before, which is a relative contraindication. As you rightly said, Anil, that if you have been into that space again, one has to be very, very cautious. So Dr. MG, can you see these? These are the straight X-rays after a post-TP repair. So these are what you can see, the tacks are there, and what is wrong in these tacks?
Can you hear me now?
Yeah, MG, yes.
There are a lot of lateral tacks which are not supposed to be there, and they are dangerous because they can cause post-operative pain.
Yes, so basically the principles which was said that you should not go below the iliopubic tract has not been adhered. And what do you think these symptoms would be post-operative?
These patients can come with a lot of pain. Pain is one of the biggest problems following these repairs.
So how would you treat this pain?
They're extremely difficult, and they are very difficult to treat depending on the situation, going from simple measures of starting with some analgesics and then gradually go upwards of, ultimately even removing the mesh. I think it's stage by stage, but they're extremely difficult problems to treat.
Yes. So I agree with you, MG, entirely. It has to be a staged thing, starting with oral analgesics, maybe nerve blocks, then maybe take out the mesh.
Yeah.
And if possible, the tackers. So the best thing is prevention. So you have to stick to your anatomy, and you have to see that you don't make this mistake. So Ramesh.
Yeah.
So we have a 55-year-old male, bilateral TAPP done 3 months ago, sinus anterior abdominal wall for 2 weeks. Scars are normal, WBC count is 11,000, CT shows mesh, minimal fluid around. So Ramesh, what would you do in this case?
The first and foremost is I would like to get a pus culture sensitivity done here.
Yeah.
And if I could do a check for atypical mycobacterium, that would be the best. If I could send this fluid for mycobacterium culture, and then also put the patient on specific antibiotics if there is a pus which shows normal bacteria. If there is no normal bacteria that is grown, then I would treat it as Mycobacterium cheiloni, which is one of the most common bacteria that causes postoperative sinuses in patients who have mesh and laparoscopic surgeries. Well, this has to be done conservatively. We have to go on for some time with antibiotics that are going to act on Mycobacterium cheiloni, and then if the patient does not respond, then we need to look at surgery and removing of the mesh.
So that one was mesh salvage. If it doesn't work, you do explantation of the mesh. Now, if it is not worked in this case, what would you do? Would you do a lap or would you do open?
I would, if this is a laparoscopic repair, I would still plan a laparoscopic repair. If I would do a diagnostic laparoscopy, and as long as it is safe there is no bowel that is densely adherent there, I can still go ahead with laparoscopic explantation because a lot of people have done that. If there is bowel which is densely adherent in that area, then I would prefer to do it from outside.
So in this case, as we said, it was a bilateral repair. So would you take out both the meshes or you remove only one mesh?
It all depends on the scan report. If the scan shows collection and infection on both sides, then I would remove both the meshes.
And after you've removed the meshes, there is a chance of recurrence, no? So what would you do if there is a recurrence?
If there is a recurrence here, then I would plan for a open hernia repair on a later date, at a later.
Okay. So again, we always choose another plane, which is very important. So Sandeep, this is
what we have normally seen is a whole lot of people after there's so much fibrosis, they do not land up with a recurrence. Means there is a good chance that it can be healed even after removing the mesh.
Yes. That's the reason I said if. Sandeep, this is another scenario, male 30 years, chronic discharging sinus for 2 months. TEP 1 year ago, CT scan collection around the mesh. Conservative treatment has not worked. So again, what I want to know, because this patient has a sinus, would you approach laparoscopically or would you excise the sinus and go by the anterior approach?
As Ramesh rightly pointed out, you can always expand the mesh, but the sinus tract has to be laid open as much as possible. You can actually do a explantation of mesh can be done laparoscopically, transabdominal, but at the same time you need to lay open the complete sinus tract. A complete wide opening of the debridement is very, very important so that the healing occurs. Otherwise, the best way is to do it open as it is being done over here. Remove all the tackers, remove the complete mesh, and lay open the sinus tract.
Yeah, so the main message is you have to remove all the entire mesh. And you have to, as Sandeep has rightly said, it's very important to remove the mesh, the sinus tract, and whether you remove the mesh laparoscopically or by open, and you try to remove all the mesh, and if possible, the tack. So we know about the prevention of mesh, proper sterilization of equipment, use autoclaved instrument, first case on the list, entire team changes glove, mesh opened on a sterile sheet, mesh should not come in contact with the skin, and as in all cases, we give prophylactic antibiotics we need to give. Now, Anil, we have this bilateral TEP 2 years ago, and there is a recurrence. So we go in laparoscopically, and you can see there is a medial recurrence. On the left side, everything is okay. There is a bit of additions there. This is on the left side, and this is the right side. There is a recurrence. So what I want to know from you, Anil, what would you do? How would you deal with this recurrence? Would you do open? Would you do laparoscopy?
If you ask me personally, obviously I would do a transabdominal pre-peritoneal repair for this patient, a TAPP repair.
Yeah,
it depends on what sort of paraphernalia one has as a surgeon, what the experience is, where you are on the learning curve and stuff like that. Well, as far as guidelines are concerned, like in fact Dr. Kuller mentioned, I think some time ago, the guidelines are very clear. And like you also said, Ramesh, for a posterior recurrence, one must do an anterior repair. and vice versa. You know, for a recurrence following the anterior repair, one must do a posterior repair. So our guidelines are pretty clear on this, and that makes a lot of sense because then you in fact use a virgin plane that has not been used before for the repair. So your surgery becomes that much safer when you in fact use a virgin plane. Now, in centers that have been doing these hernia repairs for a while, maybe a TAPP approach could be in fact considered to be, you know, suitable as well, but that too, you know, in selected cases. Now in this patient over here, you know, I can see there in fact doesn't seem to be any mesh, you see, lower down. So that is the so-called tiger area where you have the large vessels, you know, that in fact lie on the floor over there. And that is the sort of area that I'm really worried about, you know, as far as fibrosis is concerned and mesh adherence to the underlying vascular structures is concerned. Now, in this patient, that particular area doesn't seem too bad to me. So my approach for this sort of a patient would be, again, first a diagnostic laparoscopy, which comes with a TAPP. If I find it suitable, I would then proceed to a TAPP repair. But then by and large, for this sort of a patient, one must consider first doing, you know, perhaps a Liechtenstein repair for a recurrence following a posterior.
Perfect, perfect. Absolutely perfect answer. So what we did, prevention should be there. So how do we prevent? The main thing is getting the entire space. You have to make a big space. So you can put at least a 15 by 12 mesh, which is properly placed. You should see that there is good peritalization of the cord, which is again, look for lipomas and exclude sliding preperitoneal fat near the hernia. So these are the things we look at. So Dr. MG, now for you, this patient is 37 years old, acute intestinal obstruction. So whenever a patient of acute intestinal obstruction comes, we have a policy of going in laparoscopically to see what type of obstruction is there. Often we find band obstructions. So in this case also, we thought we'll do that. But the only one history which patient gave was a TP done 1 week before. And we never thought it would be a complication of a TEP. But what we see here is you can see that the bowel is attached to the mesh. Now, Dr. MG, why do you think this happened? What was the cause?
Ramesh, thank you. The usual cause is a tear in the peritoneum, and though it is an extra peritoneal repair, the peritoneum has been torn and exposed, and that's the reason why bowel has got stuck to this area.
Yes. So which Rajesh very rightly said that you have to tackle all these tears. So, you know, whenever you have a rent in the peritoneum, you will have a loss of space. Sometimes the rent can be seen. And what you do, you have to put a varies in the palmous point to deflate and close the rent either by loop or endosuturing. And at the end of the procedure, you can always do a diagnostic lab to confirm that the rent has been closed. So here you can see, you know, while you are dissecting, which Rajesh also said, that it's an indirect hernia. And while you are doing this sac, you see you are trying to dissect the cord. You have made a rent into the sac. But you can still, there is no need to despair. You can carry on the dissection, dissect the entire sac, and then you can put in an endo loop. But in cases which Rajesh also showed, that you might need to suture, because it becomes a bit difficult, because with the two midline ports, it becomes too difficult. So you might have to suture. So in the first screen, you can see we've dissected the sac and put an endo loop. And in the second, we are suturing. So there are, both ways, depending on the situation, you can do either. But we always, whenever we have such situations, we always go in to a 5mm scope, and you can see what we look at. So this is very, very important. Ramesh, seroma is an expected outcome rather than a complication. It peaks about on the 7th postoperative day. That's a low level 4 evidence, and resolution is complete in 90 days. Up to 30% are symptomatic, and we need to counsel the patient, and it's detected by ultrasound. So how do you prevent seroma? If it's a large direct hernia and you're doing a laparoscopic repair, Ramesh, how do you prevent this seroma? Anything you do to prevent the seroma?
So what we do is we invaginate the pseudosac. So once the hernia is completely reduced, then you get into the sac and then catch the apex of the hernial sac and then pull it inside and then invaginate the full sac and then fix it inside. This fixation can be done to the bone, to the Cooper's ligament, to the opposite side Cooper's ligament, or even to the rectus muscle or the pyramidalis muscle. And the other thing that you can do is you can even suture that triangular area, that is the Hasselbalch's triangle. You can take sutures from the rectus muscle and the lateral side and then obliterate that whole space. So the most common thing that you can do is invaginate it with one hand and then put some tacks onto the Cooper's ligament, as has been done in this video. The other thing people also try to say is make a small incision on the transversalis fascia, so that if there is a collection that gets absorbed, means it goes into the subcutaneous area and then gets absorbed.
And do you put a pressure dressing after the end of the operation?
That is always done. So once the procedure is done, we put a roller gauze ball and then put a dynaplast and put a pressure.
So we always preoperatively counsel the patient, but if you have a seroma, how do you go about the management of the seroma?
The first thing, as you said, is every patient we take for inguinal hernia, we need to counsel them before surgery, saying that there can be a small seroma which may last for a little while and then it goes away, which is absolutely normal. Then the second point, I always say, that is the process of healing of the tissues there. Then the second thing that we need to tell them is not to worry for the first 3 months. Sometimes it can even take 6 months. But sometimes patients are symptomatic. And if they are symptomatic, there are times when you can, after 3 to 6 months, you can do a needle aspiration. As much as possible, this should not be done because there is a chance of introducing infection. But with total asterile techniques, you can sometimes aspirate the seroma if it is persisting for a long time and it is symptomatic.
Perfect, perfect. So this is what. So anyone who has never made a mistake, has never tried anything new, this is what, if you're doing surgeries, you are going to make. So this is the first part of this. We'll just shortly, with another 5 or 7 minutes, we'll do this decision making. Ashwin, is it all right if we take another 10 minutes for decision making in inguinal hernia surgery?
Not a problem.
Okay. So decision making in hernia surgery. So what happens, it's very important to make a decision. And what decision do you want to make? So you want to make a decision about the type of procedure. So we have open repairs, we have laparoscopic. In laparoscopic also we have TAPP, TEPP. How do you choose the procedure? And then what choices do you do in emergency surgery? So if a patient comes with acute pain, incarcerated hernia, how do you go about decision making? Then also what type of mesh, because there's so many types of meshes in the market. What is the normal size? What is the adequate size? This is another. And whether we need to fix. And if we have to fix, how do we fix? So these are the important things we have to decide. So in the type of procedure, If you look at it, surgeon-related factors are there, patient factors are there, hernia-related factors are there. But we have to remember that any decision we are going to take about what type of surgery we are going to offer to the patient, the decision has to be taken in consultation with the patient, keeping his expectations and aspirations in mind. So if you look at the type of procedure, it is very important that the surgeon, what is his training and expertise? The surgeon may be doing both types of procedures. So he can, sort of decide which is best for the patient, depending on the scenario. But if the surgeon is only doing open mesh repair, he does not do laparoscopy. So that is the only type of procedure he can offer to the patient, and there is no choice in this. Or if the surgeon is doing both laparoscopic and the open, but in laparoscopy he's only doing a TAPP or he's only doing TEPP, then he can only offer those. So when we look at patient factors, so Sandeep, in patient factors, does age have any criteria? I mean, anyway, I would say the age is all patients more than 18 years should have mesh repair. Is there any role, Sandeep, of a non-mesh repair?
The role of non-mesh repair is absolutely there in the patients who are actually coming with some sort of infection or an emergency situation, obstructed or strangulated hernias, where you cannot put a mat. There you have to rely on a tissue repair.
Yes.
If there is a strangulated repair, bowel, gangrenous bowel, definitely you cannot put a mesh. Better is you do a tissue repair, explain the patient and the relatives that there are all chances of recurrence, and if the recurrence happens, then he has to come down immediately for a
So we agree with Sandeep. So, and especially in elderly patients who are not fit for GA, we should,
lichen skin.
Yeah, or lichen skin repair. In gender, it has been seen laparoscopic repair has a lesser recurrence, which is seen in this reason, and open repair has a higher recurrence in females, and there is also a chance of a misfemoral hernia when you do open repair. Now, upon the physical activity, if it's a middle-aged active male sportsman, we should offer laparoscopic repair. And in this, if the patient is morbidly obese, it is seen that laparoscopic repair is better because the morbidity of open groin incision is much more in obese. And so again, Anil, if the patient has a previous laparotomy or a pre-peritoneal surgery, what type of procedure would you offer him? I think we have talked about this. You have adequately explained this. So we do open repair. Experts can do a TEPP. So this is, you have already covered this, Anil, very well. And Anil, I would say that if the patient has comorbidities like cirrhosis, ascites, if it has a PD catheter in place, what would you do in these cases?
See, these sort of patients, by and large, do the least that is possible. So for all practical purposes, repair the hernia, from the outside. You must let the problems that are there within the abdomen, let them stay where they are, and try and do an all open repair from the outside. The quicker the better, the lesser the better.
Yeah. So this is very important. So in your practice, you're going to come over all these situations, which is very important. So MG, if you have a primary scrotal or recurrence, again, I think this has been done with preferably open. Experts may do laparoscopy. And again, primary hernia, unilateral, bilateral recurrence after open repair, laparoscopy is definitely better. So in this emergency situation, decision making, so if you see emergency, if there's a incarceration, you do exploratory laparoscopy, you reduce the contents. If you cannot reduce the contents, you might have to do a hybrid procedure where you make opening and see the contents and then carry on with laparoscopy. And what you can see is that if you have a recovery of the bowel, but there is transmural peritonitis, you close the sac and do a Lichtenstein rater. But if there is no transmural peritonitis, you can do a TEP or TAP. But if you have to resect either laparoscopically or by medial laparotomy, then you cannot do a TEP or TAPP. You have to do open repair. So this is the flow chart which shows this. Now there are certain technical aspects of it. So in open hernia, so Anil, again back to you. What mesh would you use in an open hernia?
Well, the good old polypropylene meshes may be a medium weight, large pore polypropylene mesh should work fine in this area.
So there is no confusion about this. So there's nothing much to choose. You should have this wide pole. And how do you fix, Anil? How do you fix these meshes in open repair?
Yeah, I would, fix like we do normally for an open repair, one cubic tubercle,
yes.
and then in fact along the spinal ligament, and then on to the joint tendon,
there is no
extending medially as well. That is for a standard Liechtenstein.
Yeah, perfect. So you use non-absorbals, or some people use this. So MG, if you have large direct hernias. So we've talked about this. I think we've talked about
I just wanted to make some, if with your permission, Ramesh, comments I wanted to make.
Yes.
I think, you see, we need to have a balanced approach when we come to repair of inguinal hernias. As mentioned earlier, around 20 to 30% of laparoscopic surgeons do laparoscopic hernia repair. So we are actually talking in terms of in overall, in total, if you look at the scenario, less than 10% of inguinal hernias are done laparoscopically. I think this is something what we need to keep in mind. It is the laparoscopic surgeons who are capable of doing laparoscopic hernia repair, number one. Number two, you have somebody who has got an exposure to both open and laparoscopy. He can do a balanced approach depending on the requirement for the patient. So each patient, you decide what is the best approach. The cost is not a factor today. Let's not bring cost into factor at all here. Whatever is the best for the patient is done. That is what I do. All older patients who are not fit for anesthesia, it's better to do an open repair under local anesthesia. So the risk factor is least in those patients. The mesh, what is used is, as Anil said, standard. I don't think there is any need for anything special. You just use the standard polypropylene mesh. When it comes to tackers, I prefer the absorbable tackers. And nowadays you get cartridges. So we don't reuse the tacker again. The question of what we are talking earlier of reusing tackers doesn't arise. You get cartridges, so use 5 or 10 and be done with that. So there is no question of reusing the tacker again. And very minimal, you hardly need 2 or 3 tackers, 2 tackers for a TEP repair. You don't require more than that. And in TAPP repair, you may require a few more tackers, but it's all absorbable tackers, not metal trackers. This is what I use. And so I wanted to say, if it's a large direct hernia, depending on the size of the hernia, you can decide what has to be done. I have found that laparoscopic results, if it is a large hernia, the scrotum becomes very big. And so I have found this better to be done by open repairs. Very small direct hernias in old people, you can ignore. You need not do anything unless there is some patient has got complaints. You did ask a question saying that, you need not do a hernia at all in an old person who has got a small or a medium direct hernia with no complications. You can just keep him under observation. That also is possible. So this is my comments.
Yeah, I agree with you absolutely, MG. What you've said is absolutely correct. It has to be a tailored approach. It's not just because you can do it laparoscopically, so you have to do everything laparoscopically. What I was just saying, that these are certain technical aspects if you're doing a laparoscopic repair, and which we have talked about also. This is one thing which you do to prevent seroma. And Ramesh, what type of mesh would you use if you're using a laparoscopic repair? what mesh and what is the size of the mesh would you advocate in a laparoscopic repair?
See, right now we talk about a minimum of 12 centimeters by 15 centimeters mesh, but as far as possible, we keep it at least 13 centimeters wherever possible. I normally, I have my own algorithm. A person who is less than 5 feet 6 inches, I keep it as 12 by 15, and then people taller than that, I make it bigger.
And what about the type of
it is a medium weight polypropylene mesh that I use.
Okay. And what about fixation? You know, there are some studies which have shown that, the recurrence rate do not vary if there are no fixation. So Dr. MG is very well said about the fixation if you use the tuckers, but do you fix or you don't you fix?
I am still fixing, but I go on a balance. We had started with 4 fixations, one, and then now we have come down to 2 or maximum 3 tags in a case.
Yeah.
So we try to use as less as possible, but
fixation is being done by most of us. And so, Sandeep, what is your opinion when you combine inguinal hernia with other procedures? Would you combine laparoscopic inguinal hernia with a lap chole or a TURP?
See, a simple, straightforward, uninfected lap chole I may combine with. But I used to combine with TURP, but after one incidence of severe epididymoarthritis to one of my patients, I stopped combining it with TURP. So I don't combine it with TURP. I always try that patient gets his TURP first, and then after 4 to 6 weeks, I ask him to come back for a hernia repair, because prostate is one of the causative factors of hernia, and therefore it has to be cured completely to avoid any recurrences. Regarding lap chole, if it is not an acute gallbladder, if the sonography report is okay, I may combine with lap chole.
Okay. So ideally, if we say we should avoid, but as you said, in your circumstances, it can be combined, but TURP is no. And if you ideally go, then you go for an open repair. But whatever you do, you need to counsel the patient, which is very important to take the patient into confidence. So to conclude, decisions should be made, all the decisions which we make regarding the choice of procedure, the mesh, should be done in consultation with the patient, and you are considering the patient's expectations have to be given a priority, which is very important. We have to look at patient-related factors, hernia-related factors, skills of surgeon, but our ultimate aim is safe surgery tailored to the needs of the patient. So I would like to thank my esteemed panelists for a wonderful session, for being with me for all this while. And I would like to thank Kritika and the entire team and Ashwin and Kanavel for organizing this show. If there are any questions, me and our panelists are ready to take those questions.
I think just 3 or 4 questions, sir. I'll just pass on the questions.
Yeah.
It's directed to the panelists.
Yeah.
What could be the cost for intestinal obstruction immediately post TEP repair?
In this, it was already shown in this video, because there was a rent in the peritoneum, and the bowel went through the rent in the peritoneum and caused obstruction. So it was basically the rent in the peritoneum. That was the cause.
Is it important for beginners to put in a 5 mm scope and make sure that there are no rents post TEP repairs, or you think that is an overdue?
No. See, whenever you suspect, so while you're doing the case, and when you're suspecting there is a loss of space and you've had to put a Verwees needle and you've not been able to see the this defect, or if it's a big defect which you've sutured but you're not sure whether it's done it, it's never a bad overdue. You see, for the safety of the patient, nothing is overdue. We often do this, put a 5 millimeter scope and have a look inside after so many years of doing inguinal hernia surgery, laparoscopy. So I don't think it's overdue. Whatever you think at that particular moment is good and safe for the patient, please do it. Nothing is overdue.
TAPP or TEP, which is better, is the question, sir. I think probably you can highlight the situations where one would be better over the other, so that it makes it more easier for them.
Though I would ask Anil to answer this question. Anil, would you like to answer this question?
Yeah, thanks, Ramesh. So it is not, like we have been seeing and hearing multiple times before, it is not a TEP versus a TAPP situation at all in hernia surgery. Both procedures are in fact complementary to each other. A so-called TEP surgeon would need to fall back TAPP repair for in fact different situations, when there is trouble, when there is a large hernia, when there is a difficult situation, when there is a sliding hernia, when there is an incarcerated hernia. It is much safer to do a TAPP rather than a TEP. So I would not, see this thing as a TEP versus a TAP situation. You must know both. You must, in fact, slowly, like by and by, as you start doing more and more hernias, you must get yourself into a situation where you can do both. But there are, in fact, specific indications for doing TAPP repair for groin hernias that I've mentioned already. So know both. They are both complementary procedures to each other.
Well.
So you can stop sharing your screen so that all the people would be visible in the gallery view.
Yeah. Okay.
So you had briefly touched upon this point. Can we combine TURP with inguinal hernia repair? If we can combine, what should be done first?
No, actually, what the evidence or whatever it says, because see what happens when you're doing TURP, there is some transmigration of the bacteria. There is going to be a bit of bacteremia in the blood. And if you have mesh infection, it's a very big problem. So I personally would say that we do TURP, wait for a certain period of time, and then take up the hernia repair instead of doing both. But I would ask the panelists if anyone would, differ from my view and have something else to add. Any of the panelists? Sandeep has already spoken. Ramesh, MG, Anil.
Yeah, see, it's very clear, Ramesh. Since hernia repair involves the placement of a prosthetic mesh, the setting of surgery has to be clean surgery. But then with a TURP, there can be a situation, like you said, there is brief period of septicemia, bacteremia within the body, which is not something good when you are placing a prosthetic mesh. So as far as possible, try and do hernia repairs, stand alone by themselves, unless it's a small procedure that needs to be done additionally. So by and large, do hernia repairs with mesh, just as standalone procedures. That is my point.
I think, Ashwin, the message is very clear. So except for exceptional circumstances, we stick to this. This is what we would suggest.
Perfect, sir. So when there's a large pseudosac and we fix the pseudosac to the Coopers, do we have to decrease the pressure? That is what the question is, sir.
So Ramesh, what do you say about that?
That doesn't really matter. Even in the same pressure, you can just invaginate and then fix it to the Cooper's ligament. You don't have to reduce the pressure.
Thank you, sir. The next question is, when there is a large indirect sac and you divide the peritoneal sac, what do you do with the distal remnant sac?
Yes.
We'll leave
Yes.
it.
MG, what do you say about that?
See, I think Rajesh Kullar clearly mentioned there what to do. He put a ligature and left it open. So I think it's already been covered. So if you
Yes.
have a large indirect sac, you ligate it on the proximal side towards the peritoneum and leave the other side open to prevent any fluid collection.
Is there any advantage to using all these 3D meshes compared to a conventional flat Prolene mesh?
MG, your take again.
No, I think you want to help some people. You can do that, but I personally do not think they have. For me, they have no role. I have used them, but I don't think they make any difference. The best is.
Sandeep, would you like to add something, Sandeep?
No, I don't want to, unless I am holding a conference, I'm not going to use it.
So yeah, I think Sandeep has been the most forthright. He's really hit the nail on the head. So perfect. Okay. Next.
So that's pretty much it. Most of the other questions are an overlap. I would like to take this opportunity to thank Dr. Ramesh Agarwal, the President HSI, for conceiving this idea and coming up with a wonderful masterclass program. I would also like to take the opportunity to thank all the esteemed panelists who have taken their time on a free day and be part of us. Thank you so much, sir. Looking forward to meeting you all in the future programs.
No, so we tell them about the future programs, subsequent programs. Tell them the dates now.
So the next masterclass is going to be on ventral hernia. So we have split up the ventral hernia sessions into 2 sessions. The session 1 is going to be held on Saturday between 6 p.m. to 8 p.m. on 27th July. So we will be sending you all those details.
27 June, not July.
27th June. So we'll be sending those details shortly and looking forward to meeting you all once again there. This program is already available in the Facebook page of HSI, and it is also available in the YouTube page of HSI. So whenever you want to refer to something or you're interested to view the program again, you can take this opportunity. Thank you so much, sir. Looking forward to meeting you all in the next program. All of you, please stay safe.
Ventral hernia 2 again after 7 days.
Correct, sir.
And yeah, thank you very much.
Thank you. Bye-bye.
Thank you.
I'd like to also thank the entire Docplexus team for their wonderful support and coordination for a smooth program. Looking forward for the next interaction and meet with them as well.
And also a very long relationship with Docplexus. And they are really amazing. Thank you.
Bye-bye, sir.
Nice meeting you all. Thank you.
Bye-bye, all of you. Thank you. Bye.